Welcome to The Helping Conversation, an exploration and celebration of the practice, art, and science of facilitating trusting, safe, inclusive, and effective helping conversations with others. The helping conversation is at the core of the sacred partnership between two people when one is there to help the other. Recorded at RockVox Recording and Production Studios, Rochester, New York. Find your voice and broadcast it to the world at RockVox, rockvox.com. And now your host of The Helping Conversation, Keith Greer.
Welcome. Thanks for sitting in with us today on this episode of The Helping Conversation. As many of you know, I have a lot of background, and we've talked in previous episodes with folks around the topic of substance use disorder and the epidemic that is continuing to ravage our community, especially around opioid use disorder, all of this exacerbated by the coming of COVID-19. Over the last few years, I know I've been reading a lot more about this concept of telemedicine. And I have to admit that at first it was pretty foreign to me as someone who was, raised clinically that you do your work in your office face-to-face with your client. And yet, we're going to talk much further today with our guest about this. The evidence around the efficacy of telemedicine, there's no question that it is a way to go that we need to embrace. And quite honestly, COVID-19 just jump-started that process for many of us, that it gave us no choice but to become more comfortable with the technology and how to use it in our work in all of the different ways that we might facilitate a helping conversation. So I would ask you to join me in welcoming our guest for this episode of The Helping Conversation, Dr. Mike Pantalon. Good afternoon, Mike.
Hi, Keith. Thanks for having me.
Thanks for being here. Mike's joining us on Zoom from the Yale University area in Connecticut. So let me fill you in a little bit on Mike's background, and then we'll jump right in. Like all of us, Dr. Mike Pantalon is frustrated with how difficult it is to find good addiction treatment these days. In fact, only 1 out of every 10 people is in any formal addiction treatment, and fewer still in treatment scientifically shown to be effective or what we call evidence-based. Worse yet, individuals with addictions and their loved ones are confused about who can educate them about the various treatment options available and motivate them to make a change. Given this, Dr. Pantalon's mission is addiction help for all, those words in caps, through professional recovery coach training at his Center for Progressive Recovery, where Dr. Pantalon is co-founder and CEO and helped to create and launch a text-based recovery coaching program called recoverypad.com, and we will talk further about that. Dr. Pantalon also is a clinical psychologist and senior research scientist at the Yale School of Medicine, where he's been developing and studying cutting-edge treatments for alcohol, cocaine, opioid, and tobacco use disorders, as well as training hundreds of clinicians and coaches in evidence-based addiction treatments since 1997. Dr. Pantalon earned his BA in psychology from Binghamton University, his MA and Ph.D. in clinical and school psychology from Hofstra University, and his MS in psychopharmacology from the Massachusetts School of Professional Psychology. He received the Distinguished Faculty Award for Teaching from Yale's School of Medicine's Department of Psychiatry in 2007, and he also maintains an addiction psychotherapy practice in New Haven, Connecticut. And again, Mike, thanks for sitting in with us today.
Thank you, Keith.
So before we jump into some of the really specific and very exciting things that you were doing, I always like to start this conversation with my guests about where this started for you. So here you are well into a very distinguished career doing your unique version of the helping conversation. How did this whole thing get started for you?
It's been a journey for me to look back and figure out how that happened. Because, as most know, you don't know what today's experience is going to cause and create and what ripple effects. So I'm going to do it sort of in reverse by looking back at some pretty seminal points, I think, in my life as I've experienced it, but one, the first, as was told to me. So when I was a little kid, I mean, 1, 2, 3, my dad was the superintendent of an apartment building in Queens, New York. So
Okay.
humble beginnings for
Yeah.
sure. And, you know, he'd do work around the building, often in the lobby. And my favorite place was to stand at the front door and as a 2-year-old, ask anyone who came in, how are you doing? How was your day? I mean, it's just kind of remarkable. And that's like family folklore.
Yeah.
You know, they'd poke fun at me at times and say, well, what happened to that very friendly guy at different points? But I do think it began there.
Yeah.
Another aspect of my career that, you know, you just mentioned is opioid use disorder. I didn't really know for years why I landed specifically in that. And I could always point back to, well, I researched this and then I did work with these kinds of patients and so on. But really, Keith, if I go back, it's when I was 8 or 9 years old and started trying to hang out with the high schoolers on my block in Queens. And 2 boys in particular who had a basement rock band that I would go and listen to at their basement window on the driveway, and who eventually let me come in and listen, and they taught me how to play the guitar, and they loaned me their stuff. It was just, I was in heaven, and I, lifelong musician and love music, and I remember them turning me on to Clapton and everything like that. But the sad part of it is that these were 2 brothers who had very serious opioid use disorder, and I knew nothing about it then, and I think that's why it got locked in. For quite a long time. But the hurt of their loss, both through overdoses, stayed with me for many, many years. And you might think, gee, this guy's a shrink and he couldn't figure that out sooner. But it just goes to show you how deeply locked in these things are and how open you have to be to thinking about, you know, what brought you to where you are. So I think really that laid the groundwork. I know we're gonna talk more about how we get into helping conversations. But that was really the beginning, and then working through the crack epidemic in the 90s and really trying to wrap my head around what new ways can we have conversations with patients and clients who are having these problems to really forge a new way forward, because they were not listening to us, we were not listening to them. And I think for me, another seminal point was discovering motivational interviewing and making great use of that. Bringing that to my work here at Yale, and the rest you've already started to cover. That's the journey.
So I'm curious about maybe a specific moment in that journey, because, you know, as you know, I've worked in the field for almost 40 years, and our field is still, and I say this with great love in my heart, still pretty guilty of doing things because, quote, that's how we've always done them. And so I'm curious for you, where in that journey it really struck you that we have to move in a different direction, we have to look at the research, and we have to really develop some evidence-based ways of being.
Right. So in the very early 90s, during the crack epidemic, I wanted to be a frontline clinician, a psychologist who worked in a hospital in an outpatient setting, but mainly I liked emergency department and inpatient work, and I was working in the South Bronx. And our patients came in, they went out, they came back in, they went out. The proverbial revolving door was really at its height at that point. And no one seemed to be struck by the fact that we were telling them the same things: take your medicine, go to therapy, make sure you make your appointment when you leave here. And only about 13% of those people ever did that. And we brought it to the hospital's attention because that was a quality assurance project we did to ascertain that. And boy, I can't tell you how happy they were to hear that. And so that's when it struck me. And so I was new at the hospital. My supervisor was new. And, you know, we both looked at each other and said, we have to do something about this. And the hospital said, no, that's fine. It's okay. And, you know, so the revolving door really helped everyone in the system, if you know what I mean. And so that's when it really struck me. There are many competing incentives here. And now, so this hospital is a great hospital. It did a lot of benefit for a lot of patients. but they were stuck in a system that was pretty, complex, that reinforced leaving this alone.
Right.
But my supervisor, who is, when I was looking through sort of some of the thoughts about what goes into this conversation, my supervisor at that time really popped into my head. He said, like I did, we need to do something about this. And he pulled out this book that had just come out and said, you and I are going to read this and teach this to each other. So my supervisor, no less, who's supposed to tell me what to do, he's telling me we're going to read it together and teach ourselves. And this book was the first edition of Motivational Interviewing, which said, as you aptly pointed out, Keith, we're doing it all wrong. Right. We're not really talking to patients.
Right.
So that was the moment.
Right.
Yeah.
So I want to make sure that through our time together, we cover both your work with the Center for Progressive Recovery and definitely hit on recovery paths. So let's start with the center. So talk a little bit about what that is, what the goal of the center is, and people who are familiar with me have heard me talk about some of the training that I do more around a peer recovery coach. Mm-hmm. You're talking about a whole nother level of coach training to work with substance use disorder.
And this is why I talk to very few podcast people, but you I immediately say yes to, because you know these differences and your audience needs to know. So the Center for Progressive Recovery, that's not my private practice. It's a training company that trains people to become progressive recovery coaches and offers them a platform on which to work and do text-based recovery coaching with clients. But the model there actually was informed by that work I was just talking about in the Bronx many years ago, because what we ultimately did with motivational interviewing was to really pare it down and make it a brief intervention that undergraduates from Fordham University could do and do effectively well with our patients.
Right.
So that's where I got the bug that it doesn't take a licensed healthcare professional to effectively help someone with addiction. And that's why I said, we're going to train coaches. If we can't get physicians to do this, if I can't get psychologists to do this, then let's train those who are already motivated. So about half of our coaches are peers, so to speak, but I'd like to make that a little more specific.
Yeah.
They are people with lived experience around addiction. They've either had addictions and are in long-term recovery, or someone close to them has, and they've been through it.
Right.
So lived experience is a critical component for at least half of our coaches, and they have the best of both worlds, lived experience and professional training. But to simply call recovery coaches peers, I don't think does our coaches justice, at least because they are at the level of a board-certified professional coach. And so we help them learn how to tap into their lived experience, explain it, not impose it. But we also teach them about evidence-based conversation strategies, such as motivational interviewing, to meet people where they are, to engage them based on what they want to do and how far they want to go and based on their motives, so that we can not only make help more accessible because the coach is more accessible and texting is more accessible, but it's easier for people to connect with someone who's meeting them where they are.
Right.
So the center trains them to do that.
And when you say meeting them where they are, you truly mean it, because that's one of those statements in the helping world we love to throw out. Well, all of us helping people are supposed to meet our clients where they're at.
Right.
But the world of substance use disorder treatment and recovery has a long history of saying that and then not doing it.
Right.
So you're going to do recovery as I tell you, or based on my definition, or within the narrow scope of abstinence only or 12-step only. Right. You're training people to walk in with the skills, beginning with the listening skills, to truly engage somebody, and to honor. And this was one of the first places I really heard this word, because just so people know, I've trained with Mike around progressive recovery. I've come through his training program. This concept of autonomy, of treating folks with true autonomy.
Yeah. No. So what I appreciate is that you just gave the core elements of having someone listen to you, because before you can even meet them where they're at, you need to know where they're at.
Right.
In order to know where they're at, They need to tell you. You need to be able to elicit that from them and listen. So the core things there are to really prove that you're not going to impose, and letting them know that they're in the driver's seat. So that's out of the gate. That's the first thing that I do. I can't force you to do this. And I'm not going to allow or work with someone who's with you telling you what to do. They can wish, they can even demand if they want, but you're in the driver's seat. I can't tell you, like, that's a light bulb.
Yeah.
For so many people.
Yeah.
But you're right. You need to prove it. It's not just lip service, like you said. So many people say it.
Right.
Yeah.
Since I went through your training and incorporate what I learned into the work that I do, and this is very true, I've had a number of clients who, by the time they made it to me, have had some experience in some of the more traditional treatment environments, who, when I take this stance with them of autonomy, I either see it on their face or they have told me directly, I don't believe you. Yeah. You're going to eventually tell me what to do, because that's what every helping person has done. And so that proving it part, that no, I'm not, this is going to be a different conversation. Yeah.
And unfortunately, I just had someone in that situation a couple of days ago tested. This is someone who's in our intensive program in my private practice, a lot of wraparound services from multiple people for several weeks straight. Yes, you could send someone to rehab, but this person's been to rehab multiple times and just came out of one and is already struggling.
Right.
But both he and his wife said, so what are the parameters here? And I said, well, what do you mean? Parameters of treatment, parameters of session length? No, what are the parameters? What gets my husband kicked out of the program? And he's there, nodding. Yeah.
Right.
Well, I mean, if you're in grave medical or physical danger and need to be put in a hospital, then we're going to get you the right level of care. But I'm going to work with you through the time period we've agreed to, no matter what, barring something like that. And, they were like, oh, okay, that sounds progressive. That sounds nice. But, unfortunately, the husband who has the alcohol use disorder, I do think to some degree, one factor was to test that and proceeded to drink quite heavily for 2 days.
Right.
And refused to send notifications of the blood alcohol content, which is one thing that we often need to do, but through telehealth, you need to figure out systems where they can confidentially send it to you.
Right.
But I stuck with them.
Right.
And I did my work. And I said, no, we can't have a session when it's 0.208.
Right.
It needs to be 0.08.
Right.
But I'm not kicking you out.
Yeah.
And they were shocked. And, they kept sending readings. And when it was 0.10, and that's where I felt I was really being tested.
Yeah.
So is that close enough?
Yeah.
What do you think I did? I met with them.
You met with them, right?
Yeah, of course. And they were shocked. And the issue really was, I feel like this is being imposed on me. And no one is imposing.
Right.
People have heard it so much, Keith, that even if you say it, mean it, and prove it, they're still going to hear it the other way.
Yeah.
And so meeting with them, sticking with them, and explicitly again saying, see, it's really up to you.
Right. And I always, when I hear these stories, it never ceases to sadden me that somehow we have gotten to this place in the treatment of this very complex disease, leaving people with the understanding that if they don't do X, Y, and Z, we will, quote, kick them out. We don't do that conversation with any other disease state except for addiction.
That's right. Right. Even though folks with asthma, diabetes, and hypertension, the other chronic medical problems, can have more imminent, serious health consequences, including death, than addiction. Everyone says, well, if they don't do this, then it's going to be on me if they use a certain amount and they overdose.
Right.
It may be on you if you kick them out when you could have worked with them.
Right.
Yeah.
So can you talk a little bit about the concept of motivational interviewing, a little bit of what it is and how you incorporate it into training the coaches that you work with.
Sure. So the coaches that you mentioned who get trained at the Center for Progressive Recovery, I mean, it's an online, self-paced, live and interactive, but also a lot of video and audio content. They get 65 hours of the whole comprehensive course. But a key component is this helping conversation that's based on motivational interviewing.
Right.
And at this point, my adaptation of it, which has been to make it briefer, more medically focused, because a lot of patients need it to be motivated to be open to medications,
right,
and to make it such that non-licensed healthcare professionals can do it. I've basically created my own adaptation of it in different forms. Like in my book, it was called Instant Influence.
right.
In our studies in the emergency department, where it's super, super quick, it's the Yale brief intervention or the brief negotiation interview. And for me, it has 4 key components. The first one you covered, and you covered really well, it's autonomy. You explicitly, clearly, and sometimes repeatedly tell somebody this is up to them.
Yeah.
Where would you like to go? What would you like to do, if anything? Because you may choose nothing.
Right.
I can't force you to do anything. The second part is to help them give themselves some feedback, some constructive feedback. It's only after that that I could ever hope to give them some medical or psychological feedback that would be helpful.
Right.
So basically, that constructive feedback is eliciting from them what negative consequences have they encountered as a result of their use. And even if they say, oh, I don't have a drug problem, I don't have an alcohol problem, but has the use of these on occasion caused some problems? And you see how we're just trying to elicit their voice. But the heart of it really, as you well know, is that third step where you ask somebody on a scale from 1 to 10, how ready might you be to do this one next thing? And to be able, as a coach or clinician, to really think through what the next step or first step someone might be open to doing, and then asking them this quirky kind of 1 to 10 question. That's the key to it. So, for example, Mike, how ready are you on a scale of 1 to 10 to make sure you don't take a sip of this cup of coffee on Keith's show? And 1 means not at all ready, 10 means totally ready. But the key here is when patients tell me really low numbers, like 2, 3, or 4, and they expect me to beat them up over it verbally, I say, well, that's something. That's 30%, that's 20% there. Why didn't you pick a lower number?
Yeah.
And that just stuns people. And sometimes they answer the wrong question. They say, oh, I know, I should change. No. I'm saying you have this much motivation. I would always much rather know why you have this much than why you don't have this much.
Right.
And then from there, the last step is to make a plan. And it's really like, what's your next step, if any? And it's up to them. And we help connect them to services. But that's our 4-step adaptation of motivational interviewing, and it has worked stunningly well with people with alcohol problems, with opioid problems, to help them get into treatment, with tobacco, with asthma control. We're starting to look at it for cardiac rehab now. So it's been very powerful.
I have to tell you, I've been lucky enough through my career to have a series of very transformational experiences that have impacted me professionally and how I think. And my experience in going through the training with you was one of those transformational experiences from the standpoint of this concept of autonomy. And I know you speak about this in your book. Everybody has enough motivation, right? Our job is just help them find it, but everyone has it. And those 4 questions, especially that one, oh, how come you didn't choose a lower number? Continues to blow me away every time I use that strategy, because it's just such a different way than as you said, how people are used to, where they're used to, I pick a 3 and the helping person beats me up for not being a 5.
Right. And for me, and I appreciate that, and there's nothing like training someone like you, Keith, who not only gets it, but integrates it, mixes it up with everything else, and really can beautifully convey it and as succinctly as you do. And I'm sure you do great with clients. But if your listeners now are wondering, okay, I buy it, I get it, there's evidence, it sounds more person-centered and empathic,
Right.
positive. How could I do some of this? Do I have to, be a healthcare professional or a certified coach to do it? Well, you can do a little bit of it right now, as long as you maintain the mindset of you'd rather know why they have any motivation at all,
Right.
the person you'd like to have change,
Right.
versus why they're not more motivated or why they're not doing other things.
Right. Right.
Yeah.
In the training for your coaches, you use this acronym NEAR, NEAR. Can you talk a little bit about what that is? Because those are some very specific skills that you also challenge the coaches you train to develop.
Right. And so just by way of starting to describe that, the reason we're spending so much time training coaches is that for almost 30 years, my expertise, whether I decided it to be or not, but it became translating evidence-based practices around addiction for virtually anyone to be able to do it.
Right.
And we're not going to have enough licensed healthcare providers. They're all busy doing all sorts of COVID-related things now.
Right.
People are not, 14.5 million people lost their health insurance so far in the last 5 months of this pandemic.
Right.
So what really lights me up is the idea that we can train people who are coaches in a professional way
Right.
to be able to help the millions upon millions of people who have addiction, only 1/10 of which at best are in any form of treatment.
Right.
So the NEAR really allows the coach to help people navigate treatment and the treatment systems, as complex they are, and to find good evidence-based treatment, and not necessarily rehab,
Right.
to your listeners. That sometimes can cause more problems. Engagement is the E, how to engage someone. That's where the motivational interviewing comes in, because you need to prove that you're really going to meet them where they are and have some skill in motivating not only them, but their families as well. The A stands for accompaniment. Now I've motivated you. I've engaged you in treatment. You have a therapist and maybe a primary care provider who's prescribing you a medication for alcohol use disorder or opioid use disorder, but you need the support and the accompaniment to keep that up, to plan in reminders, to prompt you to do the homework that your therapist said would be helpful to do, how to put your coping strategies into effect, or to be a relapse prevention partner.
Right.
Kind of like an AA sponsor might, but from a very different theoretical perspective. And the R stands for reducing relapses. And that doesn't necessarily mean that someone is 100% abstinent from the substance that gave them the problem. It just means that we're going to help prevent them from getting back to the level that they were at before. Right. So lapses need to be tolerated, just like with that patient I mentioned before. And our coaches at least know how to manage that.
So then this is a model of recovery coaching that would accept like the concept of harm reduction or moderation.
Absolutely. Yes.
Right.
Yeah, absolutely. And, even the word accept, it's not up to me to accept.
Right.
I'm with you on your journey. I've been given that honor. And even when I act as a licensed healthcare provider, I try to do that as much as is possible, given legal and ethical standards that haven't caught up with this model. But coaches can really, if you have a loved one, whether it's a young adult, an adolescent, or a spouse who is resistant to treatment because understandably they're fearing that they're going to be told what to do, and that may even exacerbate the problem, one of our coaches may be right for you, because they will say to your partner, what do you want to do about this? Right. Don't worry about what your wife or your mom or your dad think. Where would you like to go? What's one step better that you would like to do? And that's what the coach do. Yeah.
So I want to go back to the end, to the navigate for a second, because you said something that I want to make sure our listeners are clear on, because the common narrative, I think, culturally is that treatment is rehab, right? So it's inpatient, it's outpatient. So when you talk about evidence-based models of treatment, could you just give maybe a couple of examples that are not that traditional rehab setting?
Right. So the most robust meaning the treatments have the most evidence, and not you. A lot of treatments can say they're evidence-based, but a robustly evidence-based treatment means it's gone through multiple randomized controlled trials. So now I'm starting to sound like Tony Fauci. Everybody knows what an RCT is now, so thank you, Dr. Fauci.
Yeah,
That makes it a lot easier. You can't have a vaccine that goes through one trial without a comparison point, or a medication for COVID without that. So I'm going to give you two examples, one of a therapy, one of a medication, that have been around for 40 some odd years, 30, 40 years, and have mounds of evidence, but you cannot get them with good fidelity in most rehabs. And that is cognitive behavioral therapy. And even though you'll see it on the brochures and the websites, cognitive behavioral therapy, and either take naltrexone or Suboxone, both of which can be used to treat opioid use disorder. And naltrexone is about the best medication that we have for alcohol use disorder. Programs don't do it. Rehab programs don't do it. They are philosophically opposed because they come from an AA or a 12-step tradition, which I respect and utilize and will help facilitate involvement with. But when it comes to, sort of basically from behind the scenes running a rehab system that doesn't give us evidence-based treatments, I say, even if it's a higher level of care, is it a better level of care? And 90% of the time it's not. There are exceptions, but 90% of the time it's not. So intensive outpatient treatment, where you get evidence-based treatments, cognitive behavioral therapy, motivational interviewing, naltrexone, Suboxone, that's where it's at. That's where people have the best chance of success.
One of my recent guests on the podcast was Dr. Trish Halligan. She's one of the leading addiction psychiatrists in my area, and she will talk for hours about the endless reams of research around the addiction medications and that continued stigma that exists even within our own treatment and recovery community, because it's, quote, not real recovery.
Well, so if we talk about evidence-based, we're going to talk about evidence-based diagnosis, and an evidence-based approach to getting someone in remission. Recovery is great. Don't get me wrong. But you have to be in remission to recover your life. Just like you can't have active cancer and do everything you were once doing in your life. You need the chemo, and you need the radiation, and you need the surgery, perhaps other treatments. That gets you in remission. It's up to you to then use that as a foundation to fully regain your life and perhaps to change it fundamentally, or to do other things. And so I love recovery, but with evidence-based coaching, we're going to get someone into remission. And then help them get a new job, a new place to live, go back to school. Our coaches are trained on that too. But recovery itself, that's defined by the person. You can be in remission and be on a medication for the treatment of addiction.
And to continue, the theme of the work of the coaches you train, even that conversation of, hey, client, you tell me how you want to define recovery, what it looks like to you. So much of what was behind my idea about doing this podcast was around how all of us who do helping conversations immediately create trust and safety with the folks we work with. And it just strikes me that everything you're talking about, Mike, around autonomy and respect and being where the client is at and trusting that they are motivated to move their lives forward, where that, the role of all of that in very quickly communicating that this is a trusting and safe space that I'm going to create for you, even if you've never experienced it before.
And that has allowed our clients, both, clients that our progressive recovery coaches work with on their own in their own practices or on Recovery Pad, the conversations are amazing. These are clients, because when it's with coaching, it's clients, not patients. But when these clients are clients who sheepishly say, so you might help me work on cutting my use from 5 bags of heroin to 4 bags of heroin? and then sort of worry what the response will be.
Yeah.
If that's what you want to do, as long as you understand that any amount of heroin
Right.
is a risk to you, which
Right.
kind of like a duh to a
Right.
heroin user, they say yes.
Yeah.
Because we know then your brain will be hooked a little bit less, and it'll be easier to do 3 and
Right.
2 and 1. And they have worked with people who literally couldn't find a treater to do that
Yeah.
with them.
Yeah.
And that's not, it's not a difference between, treatment and harm reduction. That's just good treatment
Yes.
to help somebody do better, to do what they would like to do, to move towards health.
Yeah. Yeah. It's interesting that you just said that, because I know more and more of my colleagues would be people who would say, can we just even get rid of the term harm reduction?
Yes.
That it's just good treatment.
That's right.
Right.
Addressing the DSM symptoms of substance use disorder is reducing harms. None of them speak to the quantity and frequency of use.
Yeah.
Drinking before noon, not, drinking first thing in the morning, drinking alone. None of that is in there.
Right.
It's harms associated with
Right.
it.
Right.
But people don't want to talk about that, because then that brings up the question of, could somebody use to some degree and still be in remission?
Right.
And that is possible.
And that is possible.
When they get to the severe level, it's highly unlikely and very, very difficult.
Right.
But that is possible.
Right.
Yeah.
That was the other takeaway I got from the training is which I had, the things you never think about, is the difference between somebody showing up for some kind of treatment with a diagnosis of substance use disorder mild versus substance use disorder severe, that those are not the same people.
No.
And yet have historically been given the same interventions.
Right. Right. But the worst thing is that 1 in 3 people in our country are binge drinkers.
Right.
Or high-risk drinkers.
Right.
And in many of those would now meet alcohol use disorder mild, but would never go to treatment. And who knows, if they go to most treatments, it'd probably be worse, because they would compare themselves to the others
Right.
who are severe and say, I'm fine.
Right. Right.
And there are good, easy models, quick models of treatment for those who are high-risk drinkers versus alcohol use disorder.
Look, I'm going to jump on to talk about Recovery Ped, but I do find myself more and more these days thinking about all of the people walking around who have some inkling that their alcohol or other substance use is problematic, but won't walk into a treatment program because they're under the impression they're only going to talk to me about abstinence, and I'm not there yet.
Right. Or I have to go to AA meetings.
Right.
I have to sit in groups.
Right.
I have to do it immediately. I can only go to treatment when I'm fully ready to change.
Right.
You could come in saying, I don't buy it.
Right.
I think my drinking is okay.
Right.
And our coaches know how to deal with that.
Yeah. Awesome.
Yeah.
Awesome. So let's talk about Recovery Ped, because it's such an exciting direction we're moving in around just telemedicine in general. So fill us in a little bit on what Recovery Ped is and how people could access it.
So recoverypad.com is a web app that provides text-based recovery coaching from our progressive recovery coaches. So we've trained about 86 coaches across the country, but they can text with you from wherever they are. And that is one aspect of telemedicine. I know the tele affects everyone. Tele meaning, is it the phone? I mean, that's our old term, but telehealth, telemedicine can be done via text, video like we're doing here, or just by phone audio. But the thing about the texting that we found is quite remarkable is that the in-the-moment conversation is often more helpful and more effective than virtually anything I could do when somebody gets it together enough to come to my session, to my office, or even in a video when they have to be sober enough to talk with me.
Right.
In the moment, which I understand is part of your descriptor here for helping conversations, right?
Right.
It has to be
in the moment.
In the moment, there's no modality better than text for that. Oh, you're having a craving and you're outdoors somewhere and somebody's just offered you some drugs. Let's schedule a Zoom session. It's not going to work like that.
Right.
Text me. And so that's what Recovery Pad offers. And for me now, tell me what you think, Keith, but having done a lot of this video for sessions, and it's great that we have it. I feel
Right.
fortunate that
Right.
my clients are still able to have their sessions and that I can still maintain my practice. But this is sometimes like just ones and zeros
Yeah.
to me. And when you see someone face to face, you have an expectation it's going to feel like you're in person.
Right.
And then there's the letdown. We can get used to it, but there's a letdown.
I'm with. Look, as you said, thank God we have this technology right now.
Right.
But it is not the same as being in a room with another human being.
Right.
Right.
And it's more exhausting than I think any one of us thought.
Yeah.
During this time, I've had a great experiment, a natural experiment, texting with my clients on Recovery Pad, because I can text with them there too,
Right.
or doing the video. The texting in the moment conversation feels more real because I don't have a different expectation than what I get with the text.
Right.
What I expect is what I get, different than with video.
Right.
And when a client texts me one sentence, having trouble now, and I can get to it soon enough, and I don't have to get to it immediately.
Right.
When a client sends me the text, they report feeling an immediate relief and they can hang on for a little bit. They know I'll get back to them soon enough.
Right.
Or the coaches will.
Right.
And what's going on? Let's talk about the skills we talked about last time. In the moment learning is just priceless. And that's what Recovery Pad has to offer.
Right. Right. So if somebody went to recoverypad.com, are there options on how they can engage with the program?
That's your central place. So if there's anything that you've heard here today that says, I'd love to become a coach, especially since, 14.5 million people just lost their job, and it's a great thing to be able to do from home. You go on recoverypad.com and you click either get a coach if you want to coach for yourself, or you click become a coach. It's very simple. And there's no obligation by clicking anything. And in fact, to get a coach, you can get 2 days for free to try it out. No obligation, no credit card even required, which many folks are suspicious about at first, but they're like, that's great. I don't need to give you my credit card and you won't automatically bill me. So you get 2 days to try it out.
Right.
Recoverypad.com.
That's awesome. And like unlimited texts, if I was looking to have a coach.
You can text your coach as much as you want, and a coach will get back to you at least 2 times a day, 5 days a week. If you'd rather have that be 2 days a week for longer, you can do that. But I'm telling you, Keith, the coaches who are active on the platform now, I'm telling them, hang back, don't text as much.
Right.
Let the person text.
Right.
You. So our coaches are very eager to help. They love being in this profession. And they've chosen it. It's not that someone said, oh, you're supposed to treat addiction too. They've explicitly come saying, I want to help people in this new, progressive, accessible, text-based way.
Right, right. And I assume because you don't do anything that is not evidence-based, that you've done some research around this?
Yes. So not only is the training that they get evidence-based and the strategies that they use evidence-based, we are tracking both the clients that our coaches work with independent of the platform and on the platform, but we're having some really amazing results in terms of retention and in terms of people remaining at the goals that they set for themselves. So here's the difference here. When you do a randomized controlled trial, you get all of the same patients and you have one outcome. But what I can report here is that nearly 98% of the patients who are on Recovery Pad hit their goal and maintain it.
That's awesome.
Now, we're in beta still. We're still testing it out. So as a scientist, I would say we hold out for the numbers. But in order for us to get to those numbers, people need to know that there's a place at least that they can come to and not be confronted, judged, or forced into a certain kind of program, but that they will be heard and that their goals will be worked on.
How would you answer the question? Because I'm assuming you've had this question. Is Recovery Pad, is this treatment?
Okay, good question. Keith, you're good. You're good. So it's not treatment, it's coaching. It's coaching on purpose because treaters are kind of forced by legal state regulations, ethical regulations based on their discipline, what their license requires. In order to maintain their license, they're kind of boxed into, keeping people only for a certain length of time, needing to let them go and refer on if they do this, that, or the other thing. But coaches are not regulated in that way. A coach is expected to work at the client's service rather than to treat or to prescribe. This is what you have to do. Kind of.
Right.
So we're very intentional about the choice of making this coaching, not treatment.
Right.
And it allows coaches to text you and to even, our coaches will do video sessions, though, if clients want them. That's fine, too.
Okay.
And they can do that across state lines, whereas licensed healthcare professionals cannot.
Right.
And with COVID and addiction so rampant and overdoses up 42%, families can't wait to get this kind of empathic motivational care till they can find a provider in their state. I mean, how about the rural areas?
Yeah, right. So I would also assume that one of the roles that your coaches could play is to go back to that end, navigate that in their role as a coach. Even if I'm coaching with someone who's across the country, I could assist them in identifying evidence-based treatments that are in their area.
You know how much I harped on this in the training.
Yes, I do.
And gave you guys homework. Go find an evidence-based IOP in California.
Right.
And the person says, well, Mike, I'm in Iowa. That's why I said California, because you might need to help someone there. And they've done it.
Yeah.
They've done it.
Yeah.
Yeah.
That's awesome.
The thing that I haven't mentioned is that, loved ones need help too.
Yes.
And sometimes they're the driver of sending their loved ones to rehab because understandably they need a respite. They need a break from this person. But they too can get a coach.
Okay, good. Because
it's not about treating coaching their loved one. It's about coaching them to take care of themselves,
right?
And to be as effective a communicator about what they expect from their loved one, as they can.
Right. That's awesome to hear because I've had some recent experiences with some clients I'm working with, young men, early mid-20s, and the person who had some of the most difficult time hearing how I do my work from the standpoint of autonomy, and I will not tell your son what to do, was mom or dad, because they've been steeped in this narrative that we're supposed to tell these folks what to do to find recovery. So some level of support for loved one and family, oh my, so important.
Right. Support for them, education around those, the point you brought up and around autonomy. And if they want to learn, they don't have to, but if they want to learn brief motivational interviewing, to add to this helping conversation to motivate their loved one, then the coach can teach them that as well.
That's awesome. That's some good stuff that you're doing over there, and so needed. And I have the greatest of faith will grow. So I need to ask you this question because I ask all my guests this, because for me, one of the foundations of any really good helping conversation, as you have been talking about, is to be strength-based with the folks that we work with. So fill us in on a few strengths that Dr. Mike Pantalon brings to his work. Some personal or professional strengths.
Okay. I think even with all my training and experience and help from colleagues and my wife and loved ones, I think the number one thing is my grit. I don't stop. They tell me I'm like a dog with a bone. So while that has caused trouble for me in certain areas, most of the time it's really, really helpful. And so I don't give up.
Yeah.
And like I proved to that patient I mentioned before, I'll keep going. And when my clinicians or interns say, oh, that person dropped out, we didn't kick them out, that person dropped out.
Right.
They'll be back.
Right.
And we'll be here.
Yeah.
So did you ask for one, Keith, or did you?
Oh, you go. I'll give you a couple of minutes here to brag about yourself. That's what we do with, ask our clients to do.
Well, I'd like to think that my buddies who sadly departed this earth too soon taught me at the very beginning how to be creative with a guitar. And while, mind you,
That's awesome.
I'm not a pro,
Yeah.
I think they instilled in me not just this desire to work with people with addiction, but of creativity.
Yeah.
And if there's anyone here at Yale, they'd tell you that, Mike does things his own kind of different. And while that too has provoked some challenges, I wouldn't give it up.
Yeah.
So I don't think that I didn't know 10 years ago I was going to be doing this, but creatively, thinking about what we can do and the workarounds, rather than, as you aptly pointed out at the beginning, this is just how we've always done it.
Right.
And while Yale is an immensely creative place, it is also steeped in over 300 years of this is tradition.
Right.
So it's both been a great and difficult place to do it. I guess the last one is not so much me, but I would have to mention that my early supervisors, one in particular, the one in the Bronx, and my wife and some of my own spiritual traditions encouraged me to always think about what I don't know more than what I do.
Yeah. Yeah.
And to quote my current favorite Netflix show, Dark, what we know is a drop.
Right.
And what we don't know is a vast ocean.
Yeah.
And I'm comfortable in that ocean.
Yeah, right. Well, that keeps us learning, right?
It
keeps us learning, curious, maybe even a little bit humble in the work that we do.
I try, although I just rattled off 3 strengths. So
that is, look, I have this exercise that I do with almost every single person that I coach with, that I challenge them to, because this seems to be so difficult for us human beings, to create a list of strengths, talents, skills, positive attributes, and there needs to be on their list as many items as they are old. And when I ask that of anyone who's older than 10, they look at me just like that face you just gave, like I'm crazy. Yeah. But it's a fascinating dynamic for me as somebody who engages in a helping conversation of how quickly most of us human beings go to what we believe isn't good about us, that kind of inner self-critic, and have such difficulty identifying what's in my toolbox. What do I use?
Keith, I don't know that I could do that, but what I'm going to take from you today, which I for me is more important than anything I said, and that is that I think my self-care and all helpers during this crisis who are doing this video thing should at least be mindful of what Keith just said and try. Just add 1 a day.
There you go.
And then it'll take, scores of days for us to come up with all of them. But that's great, because we need to stay up and optimistic too, because there are many other treaters around us who are very dark and gloomy about addiction.
Yeah.
There is hope.
There is hope. And look, and even that's a balance, because there is hope. I mean, I'm more jazzed about the work I do now than I was when I started my career. And yet we also can say very honestly, it's not easy work for us as human beings around this issue of substance use disorder. And so finding that middle of remaining hopeful and optimistic, and am I in a moment where, as you just said, I really need to focus on taking care of myself right now. I think that's one of those other challenges that are there every day, no matter how long you do this work.
Right.
Yeah,
I agree.
So again, just so people hear it again, the website that people could go to if they're interested in either finding a recovery coach, or interested in maybe exploring a little bit more of your training.
So we made it simple. Both are at recoverypad.com. So it's recovery, PAD, all one word, recoverypad.com. If you want a coach, click Get a Coach. And if you want to become one or learn more about becoming one, click Become a Coach. So
Beautiful.
And if you're not yet convinced and you want to learn more, you can read more on the website. We have a video that does a nice, quick job of that.
Awesome. Dr. Mike Pantalon, thank you so much for sitting in with us today. This was great. And Mike and I were talking a little bit before we started recording. We've interacted with each other for the last X number of years, and it's the first time we've laid eyes on each other. So that was a wonderful extra gift of doing it this way.
Thank you. I appreciate it too. I appreciate your voice and your, easy approach to doing this. You're a pro, and to raising our voices around the right kinds of conversations. I wish you all the best with the podcast and with its many ripple effects.
Great. Thank you so much. Thanks for making the time today.
Be well.
So, as I said, my work and my training with Mike's organization was truly a transformational experience for me in how I think about the work that I do, specifically within substance use disorder, and in even a more general way of this concept of autonomy, and truly believing that people have their answers, to the point where I now have this thought in my head that when a coach and their client walk in the room together, the answer is already in the room, and the coach doesn't have it. The client has it. And my job is to exemplify many of the concepts that we were just talking about with Mike, to create this space so that clients can dig into their strengths and their aptitudes and their abilities and come up with the answer that makes the most sense to them. And no matter how hard I would work, anything that came out of me couldn't come close to that, because it's just my view on the world through my eyes. So I hope you enjoyed this. Please check out Mike's website, recoverypad.com, if there's anything about today's conversation that was interesting to you. And I thank you for sitting in today as we continue to explore and celebrate the practice, art, and science of the helping conversation. Have a great day.
We thank you for sitting in on our discussion today on just one unique version of the helping conversation. We would love to hear your thoughts on today's podcast, so we sincerely invite you to follow, rate, and most importantly, review our episodes. Please join us for our next episode as we continue the exploration and celebration of the practice, art, and science of the helping conversation.